the major problem that we're facing right now is that addictive disease is being treated differently from other major medical illnesses. So the problem that we're seeing is one where patients can be in recovery, be doing well, be on their dose of medication for a period of time, and then be told, that's it, your time has expired, you've run out of time, you have to stop taking your medication. And imagine if we had to do that to a diabetic or a hypertensive. What happens then? Suddenly their blood pressure goes through the roof, or their blood sugar goes up, and with an addict, they can relapse. And it's absurd for them to be treated that way.
ASAM's been working on something we call the Patient Advocacy Task Force. And this is a group of physicians who's been working to both do surveys of all the states for coverage determinations, but also to look at really what are the data on the efficacy of the medication-assisted treatments, not only for efficacy, but also for some pharmacoeconomic data. And also what are the legalities around the issues of restricting access to care for this one specific type of disease. There is going to be a stakeholder meeting in the summer where the outcomes of the data that are being collected now are released to the public. And we're really hoping that by getting out the information on the evidence base of these treatments, that will help at the state level to counteract some of the movements to restrict care, which is based on ignorance of the efficacy, but also ignorance of the total cost of care of untreated addictive disease. 2 more points on the 100-patient limit. The first point is that as of just a few months ago, OTPs, or opioid treatment programs, or narcotic treatment programs, they have different names in different states, but the feds call them OTPs, which treat with methadone patients who've got opioid addiction, are allowed to be using buprenorphine in a way that's somewhat different than they had in the past. So a doctor in an OTP can order methadone and it can be dispensed there, and under federal law there's no number of patients who can be treated in that way. The physician now can order buprenorphine and it can be dispensed from the OTP, again without any number under federal law of how many patients can be treated in that manner if the physician is working in the OTP. And the change that has occurred there is that OTPs typically, patients have to come in every day, 6 to 7 days a week, until they can earn a take-home by having screens that are negative for drugs of abuse, by making their counseling, by being compliant and adherent with the rest of the treatment plan. What changed a few months ago was that physicians in OTP can now order, and the OTP dispense buprenorphine without the requirement for something called time and treatment. So has the patient come for months being compliant with the treatment plan before they can have a take-home. Now the physicians can order, and the OTP dispense buprenorphine from the beginning of the treatment if the physician feels if it's appropriate, and the rest of the criteria for safety of the use of the medication in the community is met. So that's one way to increase access that has occurred recently. That does not require the act of Congress to change the 100-patient limit. The other point on the 100-patient limit is one of the ways that we can really show that all of the stakeholders in the medical system that this care is required and should be allowed and also covered services because of the quality of care is if there were guidelines, if there were national guidelines on the use of medications for medication-assisted treatment for people with opioid addiction. And the ASAM Board of Directors has just voted in the last ASAM meeting here at med-sci to go forward with looking at establishing these types of practice guidelines. Now this would be something where the state regulators, legislators, and payers could feel confident that people are using the medication in ways that are clinically appropriate and should be supported rather than being restricted in some way. To answer what's so odd about it, I think we come down to some of the finances, because buprenorphine is substantially more expensive than some of the generic medications, full agonists like hydrocodone, for example. So there is no clear effect on a pharmacy benefit manager's bottom line to increase use of hydrocodone, where there is to buprenorphine. And that pharmacy benefit manager may be a state, a Medicaid plan. So there is some pressure toward decreasing the cost in the silo of the pharmacy benefit. But when we step outside of the silo and look at the totality of care, the total cost of care, the total quality of care, are patients staying out of the emergency room instead of seeking medication there for vague abdominal or headache pain when they're really simply in withdrawal? Or are patients ending up in the emergency room and then in the ICU because of motor vehicle accident trauma from their drug use? Or are patients getting unnecessary MRIs for their back pain complaints that are really related to withdrawal? When we look at the totality of care, it's a very different issue. And I'm hopeful that when the data come out from the work that the ACM Patient Advocacy Task Force has been doing this summer, when those data are available, I'm hoping that that will really show people and open their eyes to the total cost of care, the total quality of care for individual patients and populations of patients, which may help move that needle a little bit, rather than simply, again, stigmatizing and demonizing patients with addiction and the medications that are used to treat them.